Today on iConnect, I'm joined by Dr Pavan Najran, Consultant Interventional Radiologist at the Christie NHS Foundation Trust, one of the UK's leading cancer centres. Pavan specialises in liver-directed treatments, including Chemosat, a procedure that has become an important option for patients with ocular melanoma and other cancers that have spread to the liver. In this episode, we talk about how these treatments work, who they're for, and what the patient journey really looks like. We also reflect on the early days of this work, the progress being made, and the research that's opening doors for more patients, including in cancers like colorectal and breast. This is a conversation about innovation, collaboration, and the very real impact of giving people more options and more time. Pav, welcome to iConnect, and thank you very much for joining us. I've given you a brief introduction, but would you like to just explain a little bit more about yourself, your role, and where you work?
Yes, my name's Dr Pavan Najran. I'm an interventional radiologist at the Christie Hospital in Manchester, which is a specialist cancer hospital, one of the largest in Europe. And my role is an interventional radiologist. So interventional radiology in general is a relatively new specialty, and now it's really described as the fourth pillar of cancer care. So traditional therapies include chemotherapy, radiotherapy, and surgery. Now, interventional radiology is now slotted in as that fourth pillar. And what I mean by that is we are now not only diagnosing issues in the form of scanning and traditional radiology, we're actually providing therapeutic solutions. And my specialty is liver-directed therapies.
Fabulous, which is what we're going to discuss today. And the fact that your work now sits so forefront of the primary care load is wonderful. What led you into interventional radiology? Where did you start?
Well, I didn't know it existed, to be honest, when I was at medical school. Again, we were exposed to the traditional surgery and medicine elements. But when I went further into my training, so after medical school through my junior training, we get a little bit more exposure to different specialties. I actually went down the surgery route initially and did some work in Southampton. It was there I got a little bit more exposure to radiology. So there were a couple of joint cases with intervention. And I found it fantastic. It was a mixture of not only the diagnostic element of medicine, but also you're providing therapeutic options for patients. We're also providing therapeutic options in patients where traditional big operations are not really an option. But because we can do things in a minimally invasive way, we can give more options. And actually, in a lot of cases now, because of how acute and how much is developed, curative options for patients as well. So it was really a little bit of an accident. I initially was purely going to go down the surgery route. Medical school, I was one of those people who was dead keen on it, dead set. But actually, I found this really by accident and through my training.
And more at that point, where was the kind of direction towards cancer and towards the liver in particular? Because I'm sure the whole body is subject to interventional radiology, but you've chosen the liver and you've chosen cancer.
Absolutely. So again, it sort of developed through my radiology training. So training in medicine is long and exposes you to multiple different modalities. And as I went through radiology training, I got more and more exposed to this new specialty called interventional oncology. And again, it's a quite acute growth. If I go back 15 years, there wasn't much of an interventional oncology field, and a lot of the societies which now exist were non-existent 15 years ago. And so as I was going through my radiology training, a lot of new therapeutics were coming online in the form of liver-directed therapy. So I finished my training in the West Midlands and had an opportunity to go and do a fellowship at the Christie Hospital. And that's where it really pushed me along. And again, I wasn't thinking about a career purely in interventional oncology. But when I got there and I saw the effects and the development in technology, I thought I really need to be a part of this. And it was really more about the ability to do both, the ability to diagnose, but ability to treat. And that ability to treat was not only in the sort of acute setting, which is what traditional interventional radiology is, but also in the non-acute therapeutic setting, where you're working very closely with oncologists, you're working very closely with radiation oncologists and surgeons. And it really became a scenario where I was part of the, I suppose the analogy is cooks in the kitchen. So there are multiple different cooks everywhere in the kitchen. You want to make the best meal. And I was part of that team. And you really are the
Mm.
forefront of the MDT. So that's what pushed me into it. In terms of liver, I found it was really more of an accident again. When during my training, it was really the development of the therapeutics coming online. At the time, I happened to be doing my fellowship, and there was an opportunity at the Christie to drive that activity. And even if I compare, been a consultant for 10 years now. So if I compare to what it was like 10 years ago to what it is like now, it's completely changed. And that direction of travel has changed on the basis of research. And a lot of these research opportunities have come across because of the work we do at the Christie. So we are,
Okay.
I like to say, a leading light, particularly with liver-directed therapies. So it was a little bit of an accident, but a guided accident, if that makes sense. But it's a fantastic specialty to be a part of, and quite rewarding as well, actually.
Oh, no, I can imagine. I mean, there's no point in me asking you what motivates you. I can see it. It's written all over your face, and you can hear it in the way you put your role forward in medicine. And I mean, as a patient cohort, we're actually very lucky to have you. So ocular melanoma. So that's something that not a lot of people have heard of. Would you like to tell us how your role can benefit patients with metastatic ocular melanoma to the liver? What are the options that you can give?
Yeah. So again, I suppose it goes back to that analogy of multiple cooks in the kitchen. So as an interventional oncologist, we work very closely with the oncologist to ensure we provide the best therapy. So in terms of ocular melanoma, once it's spread to the liver, there are systemic options available which would be provided by the oncologist. But in conjunction with that, I can provide a treatment called chemosaturation, which is a method of delivering chemotherapy, but directly to the liver. So traditional chemotherapy is given via a little cannula or a central line or via a port. And that chemotherapy that is delivered into the body is exposed to everything. So all of your cells. So not only the cells you want to target, but everything else as well. And it is a cytotoxic agent. So it means that it does cause damage to normal cells. And that's what limits the dose you can deliver to any patient. Now, what chemosaturation does is slightly different. It's delivering really, really high dose chemotherapy to the target. So in this case, to the liver, but removing that chemotherapy before it gets a chance to have an effect to the rest of the body. So what that means is that you can deliver extremely high doses of chemotherapy to your target organ. So that in this case is the liver, and not have that really high dose chemotherapy affect the rest of the body. So two
And
elements.
how does it do that?
Yes, so it's quite complicated, but in essence, what we do is we target the liver artery first. So we pop a little tube in via the groin into the liver artery, and via that tube we deliver high dose chemotherapy. So that's in the artery directly into the organ. Now, traditionally, what would happen if we didn't have the isolation element of the procedure? Once the chemotherapy is being delivered into the liver, it leaves the liver via the veins and then would be systemically distributed. So go all around the body and expose that high dose chemotherapy to the rest of the cells. And given how high dose it is, that could be potentially fatal. So what we then do is we block off that vein from being exposed to the rest of the body by inserting a very gentle balloon, which just sits below the heart, and another balloon below it, which sits below the liver. So as all the blood leaves the liver, it goes into the tube between the two balloons. It exits the body through a little tube in the groin. That blood which leaves the patient is then cleaned and filtered with all the chemotherapy removed. That blood is then returned back into the body through the neck into the heart. So this circulation is continuous. So as I'm delivering chemotherapy into the artery, the blood is leaving the vein at the same time. So it means we have a chance of really bathing the liver in really high dose chemotherapy, which is the sort of saturation part of the name. And then we can filter out that high dose chemotherapy and return it back to the body. So delivering high dose chemotherapy without having the systemic effect it normally has.
Okay. Oh, wow. I mean, it's fabulous. And I do believe they are starting to look at trials in other cancers, not just ocular melanoma now, because they've seen that this works. And is it a reduction or is it a complete removal of tumours?
So in some case, you can have what we call a complete response, which means a complete removal of any visible disease on the scan. And in the majority of cases, we have what we call a response. So it means a reduction in the disease volume. And when you marry that, a trial which was released recently has shown with systemic therapy, it has a much better response versus a traditional chemotherapy route on its own. So we are
And
look
obviously limited side effects as well, because
correct.
it's in a controlled area, if you like.
Exactly. So when we talk about side effects, it's not just the effect it has on the patient, but also the limitations as to how much chemotherapy you can give to a patient. So if the side effects are severe, we actually have to stop treatment because, again, the chemotherapy does affect normal cells within the body. The beauty of chemosaturation is you won't have that effect because you are isolating the chemotherapy away from the rest of the body. So you're not limited by the effects that it has elsewhere. So we are in a position where we are looking at chemosaturation with regards to other disease modalities. So as you mentioned, there are trials coming online. So at the moment, I'm the chief investigator for a trial looking at the use of chemosaturation in the colorectal disease group, and that's something that we're hoping to get started very soon.
And this again is targeted to the liver. So this is metastatic colorectal cancer.
Yes, that's correct. So, disease which is spread from the primary site, and so in this case, the colon, to the liver.
Is that quite a common area for colorectal cancer to go, to the liver? I know with ocular melanoma, it's kind of the most common organ to be affected.
It is common, and also we do see it more commonly because of how prevalent colorectal cancer is versus a lot of other cancers. So we've got a larger group of patients with regards to the colorectal group, and therefore do see a lot of disease spread to the liver, and it is one of the most common places it does spread to, unfortunately.
So when you say you've got a larger cohort of patients, I mean, obviously with ocular melanoma being such a rare cancer, having that larger cohort, is that going to give us better data for the efficacy and for chemosat to be used as a more readily available treatment?
Absolutely. With a bigger cohort of patients, we have the ability to provide the treatment, and on the back of that treatment delivery, we can see and assess the efficacy of the treatment. And it is a little bit of a chicken and egg scenario when it comes to new treatment modalities and effects. We have to provide such modalities in the first place to see how effective these treatments are, which is essentially the foundations for any research. And if we can get that data to show it is effective, which anecdotally we believe it is, we can then potentially provide that treatment for more patients.
And how long does this take? Just how long do these trials take to be done, to kind of recruit the patients coming into the study and then to actually collate the data? What kind of timeline are we looking at for this? Just a matter of interest, really, Pav.
Yeah, it's quite a large piece of work. A lot of the work is actually done before the trial starts, so we have to go through a ethical assessment process. So what that means is we need to ensure that it is an ethical trial to undertake. It is done properly, and the patients are recruited appropriately. And that whole process can take probably longer than the trial in some cases. Once the trial is not online, depending on how many patients we hope to recruit and how many centres are involved, it can take up to 2 years for trials to fully recruit and close. We try and get the data out as quickly as possible. And that's because we want to make sure that if we've done the hard work and the patients have undergone these trials, we want to try and get the positive or negative effects the trials have had out to the wider medical community to see if we need to try and implement such treatment in standard of care, or B, look at an alternative method of treatment. So it is a little bit of a peaks and troughs as you go through a trial. A lot of I have to say, my experience, a lot of the times taken up setting it up in the first place. The actual trial, as it's going through its recruitment stage, is actually quite fun. It means that you are empowered in delivering treatments you believe that are effective to patients, which normally wouldn't have exposure to.
Yeah, so this isn't offered to ocular melanoma patients as a standard kind of treatment as such yet, although it's NICE approved and FDA approved. I mean, it's gone through all the hoops and it's been around for many years, actually. And I know the chemotherapy agent melphalan that's used as the drug is a well-known and well-tolerated chemotherapy drug, but it's actually the medical device itself that's got these hoops to jump through, I do believe.
That's correct. So again, I suppose it's a little bit of an effect of how quickly interventional oncology is developed as a specialty. So we have the traditional treatments in oncology of radiation, surgery, and traditional chemotherapy, and each one of those groups has a specialist funding element to it by NHS England. Interventional oncology itself falls in between a couple of these groups, and it doesn't necessarily have that funding stream to support new research. And I suppose it's a specialty that needs to be pigeonholed somewhere to ensure that we do get that funding. So at the moment, there is a little bit of a battle going on to try and get funding in place for the relatively small number of patients who would require chemosaturation in comparison to other disease modalities. And again, it's because it's classed as a device. And that's the balloon element that I discussed earlier about how the procedure works, rather than a drug. Because like you said, melphalan is a well-established chemotherapy. So it's not the melphalan we're testing in essence. It's the tools we use to deliver the melphalan and the dose we're delivering. So it is a bit frustrating as a clinician, because we do know it's effective. We do know it works. The data we have so far has been very supportive of that if it's used in the correct way. But because it's fallen in a specialty that's so new in the world of medicine, we just don't have that direct funding to try and push it further along.
And if people had to try and pay for this themselves, is that an option, and how much is it? Is there a set price, roughly?
Yes, so there is the majority of patients I treat have actually funded it themselves, and it can be done in the private sector. And each cycle is approximately 45 to 50,000 pounds, depending on where you have the procedure performed in the UK.
Okay.
And normally, most patients require 2 to 3 cycles to see a true effect, because that gives the opportunity for the liver to have a large enough volume of chemotherapy delivered over 2 to 3 separate cycles. So it is a big financial undertaking for a patient. And again, we are very selective with regards to patients who we believe are going to benefit from them. So if we believe that it's going to benefit them, we will pursue treatment for that patient. But again, it's a little bit of a chicken and egg scenario. The more patients we get through and collect data on, we can prove to the powers that be that actually it is an effective treatment, and we do need to provide some element of funding to get more patients treated appropriately.
So if you need like 2 to 3 treatments, how far apart would these treatments be, and what's the recovery from the procedure itself?
Yes, so the recovery is quite variable. A lot of my patients, they expect to be sort of bed bound for about a week, but actually they're up and about back to their normal activity within a couple of days. So I remember a fantastic patient of mine who was a really keen bowls player, and I actually performed the procedure through the wrist artery because it's far safer. And we were one of the first in the world to do that. But she was a very keen bowls player. She bowled with her left hand, which is the vessel I was hoping to use. So she made me promise that wherever I did the procedure, that her hand would be completely fine for her to crack on with her bowls championship match, which was actually 2 days after the procedure. And she went on to win it. So she went ahead, was absolutely fine, went for the match and won. So the recovery is variable, but I'm amazed to see patients up and about absolutely fine, eating and drinking normally 24 hours after the procedure. They may feel a little bit tired for about a week, so that's what we normally warn patients of. Just generally fatigued, but other than that, they're absolutely fine. But again, one of my patients managed to win a bowls championship, so it is quite variable. Sorry, in terms of the procedures itself, depending on how well the patient recovers, we normally wait around 6 to 8 weeks for the next cycle to occur. Sometimes we want to wait a little bit longer if we can adapt to patients' individual scenarios. So some patients, for example, would like to have a break and go on a trip in between their cycles, which is absolutely fine. We can delay that, but we like to do it around 6 to 8 weeks after the first cycle.
Excellent. I'm sure it'd be a very cheap holiday if you've just raised £50,000 to have a treatment done.
Absolutely.
Yeah, it'll be camping somewhere in North England, I would imagine. You did mention Southampton, and you went down to Southampton. Was it during your training or?
Yes. So I went. I went through the surgical route of training. So the way medicine works is you go and do your junior doctor training for a couple of years, and then you decide what you want to be when you want to be a grown-up doctor. So my choice was surgery. And as part of that, I fancied a change of scenery. So I went to Southampton to do my surgical training. So I believe it was 2010, maybe. I went to Southampton to do a couple of years of surgical training, which again is where I got exposed to interventional radiology down there. And that's what sort of swayed me to go into the specialty in the first place.
And I do believe you met Neil Pearce, who is an earlier guest on our podcast and very, very involved with ocular melanoma as well. Did he kind of back you in the direction of the liver? Because obviously he is hepatobiliary all the way.
Yes. So it was a bit of a shock when we were in the House of Lords and in Parliament discussing the chemosaturation and its funding. I saw Neil Pearce and I recognised him straight away. Then I looked back sort of mentally and realised that actually he was my boss 16 years ago. So yes, he was the consultant and I was the junior trainee on the ward covering surgery, and it was an element of his practice in liver surgery which pushed me towards liver-directed therapy. So essentially, we are now doing what Neil did as an open option, but in a minimally invasive way. So it was a big inspiration, but an indirect one, and it all sort of came to mind when I saw him a couple of months ago. I think it was, wasn't it? We went down.
I think we were in there in January. Yeah.
Yeah. A bit strange, but really good to see him.
And also quite ironic to come full circle. I mean, there are so many things that you could have focused on in the medical profession, and yet you're in the two main centres in the UK that deal with this chemosaturation and with an incredibly rare cancer. So, we're lucky to have you as part of our kind of cohort and part of our go-to. And thank you again very much for being with us today. So when you say not everybody would be considered for chemosaturation, what do you have, like a checklist that you'd go through?
What we do with every single patient is we review in what we call an MDT. So what that is the oncologist, myself, a surgeon, and we discuss the likely effectiveness of any particular therapy. So when it comes to chemosaturation and liver disease, some patients may have liver disease, but also disease elsewhere. And if we find that in that particular patient, the disease elsewhere is growing rapidly, but the liver is relatively stable, at that point in the patient's treatment pathway, chemosaturation is probably not the way to go. And a different therapy to tackle the other areas of disease is probably more effective. We also find that if some patients have liver disease, but it's rapidly progressing, so it's getting worse very, very quickly, and the volume of disease is very, very large, i.e., it's encompassing a large proportion of the normal liver, then chemosaturation may not be a effective treatment because in order to deliver such high dose chemotherapy to the liver, we need to make sure that the liver function itself is as normal as it can be. And if the liver function is disrupted because of such high dose, high volume disease, if we then go ahead and do a chemosaturation, it may be too much of an undertaking for the patient. So it's really for those patients who have got liver predominant disease. We do sometimes treat patients who may have one or two sites elsewhere, but it isn't really dominant, and a completely normal liver function, because we know that the patient has enough reserve to undergo the treatment.
And is this something that can be done? So, could you have a lesion in a segment of your liver, have that segment cut out, removed? Because obviously, randomly, the liver grows back. Who knew? Um, and once that's been cut out, if it was a bigger one, and then there was a couple of other kind of little ones splattered around, would you then go in with a chemosat option?
Yeah, absolutely. So some patients we see have had a resection previously to take out an area of single disease or a localized area of disease, and unfortunately it returns in the remaining liver. So subsequent resections in that particular case is probably not advisable because you need some volume of liver to ensure function. So that would be the perfect scenario where a chemosaturation would be effective because we are preserving the normal liver and we're delivering that high dose chemotherapy in the residual part of the liver, targeting all the small areas that have unfortunately returned.
And what about a multimodal approach? So, I mean, we talk about MDT, which is multidisciplinary team for those who are unaware of the kind of acronyms, but a multimodal approach to ocular melanoma. I mean, some people are about 50% of the cohort would be eligible to have tepentafusp. There are immunotherapies out there. Are we hoping that chemosat will work alongside other therapies? I mean, you mentioned
Yeah.
people with extrahepatic disease, with disease outside of the liver.
Yeah. So Chopin's, which is a trial which has just been going through the publication at the moment, has shown that if you marry chemosaturation with systemic therapy, the effect is far better than just using systemic therapy on its own. In addition to that, there are a multitude of liver-directed therapies as well. So chemosaturation is really reserved for patients with disease throughout the liver, so you can target the entire liver in one go. But if, for example, there is a small area of disease that reoccurs, then that may undergo what we call an ablation, which is where we put a needle in through the skin directly into the lesion and burn away that tissue, which is an approach we adopt with other disease groups. So, for example, the colorectal group, we routinely deliver directed therapy to one part of the liver, which has the majority of the disease, and actually may opt to use a different liver directed therapy on the other side to preserve as much liver volume as possible. So,
So not
and
only
again,
can you put a balloon top and bottom, you can actually segment the liver, can you, and treat
yes, so what you
areas of
can
it?
Yes, so what you can do is actually direct your catheter. So if we go back to the procedure itself, the chemotherapy is delivered by the tube in the artery. You can put that tube in the artery just in the right hepatic artery and just deliver the chemotherapy on the right side of the liver if you want to, preserving the majority of the liver on the left. So that's more of a targeted approach if that's something you would like to adopt. We do that in other forms of liver-directed therapy quite routinely. And again, chemosaturation is probably something we would adopt and develop further and maybe deliver more targeted therapies. But it can be performed and then potentially use different liver-directed therapy tools to target other areas if need be.
Would this work better? I know ocular melanoma is quite often it's classed as a pepper metastases, so you get dots of it all over the place. I don't know how colorectal performs, for example. So if you might get one tumor in your liver, that then would be very beneficial, I'm guessing, as a layman, just to treat that area that's got that tumor, rather than kind of flooding the entire liver with a toxic agent.
Absolutely. So the idea, you're absolutely right. So we are changing the way we do things. So if I go back 10 years, that I talked about the development of IO, we used to treat the entire liver regardless, with radiation or with chemotherapy, etc. But now we moved away from that completely. So now we are tailoring all of our treatments dependent on the patient. So, for example, like you mentioned, in the colorectal cancer group, if there's a single lesion or a couple of lesions which are occupying one part of the liver, we will only treat that part of the liver, because that would mean we can preserve the rest of it. Making sure the patient's liver function test and liver function status is maintained while delivering all of that focal therapy to the area of disease. So the way we use liver-directed therapy, I suppose, is going back to that same analogy of the chefs in the kitchen. We're using multiple different tools to get the best outcome for our patients, and
Okay.
chemosaturation is becoming a very, very key part of the whole sphere of liver-directed therapy, and we can and will develop the way we use chemosaturation. And I feel that focal therapies is something that's going to push even further.
And I know there's rumblings and talks. I think in America, are they doing this for breast cancer in the
Yeah.
liver, for metastatic breast cancer in the liver?
That's correct. So
And
similar to the trials we're starting with colorectal group, it's something that the similar trial with the breast cohort group is also coming online, potentially coming to the UK as well. I believe Southampton are going to be starting that relatively soon, and I'm sure they'll open up further centres with that. So again, it is the the so confidence in chemosaturation as a treatment option in liver-directed therapy has grown so much that now it's branching into different disease modalities.
well, this is fabulous for the ocular melanoma community. Absolutely fabulous. And developing treatments for such a rare cancer is so difficult. The main barriers seem to be, I mean, funding, then raising awareness. And actually, as we've discussed, the cohort of patients is so small. So the fact that we've been able to branch out now, I mean, this is wonderful for you guys. You must feel like you've really hit a kind of eureka moment in curing cancers.
I think a huge thanks has to go to Ocular Melanoma UK. So when I was first invited to come and talk a couple of years ago, I was blown away by the community, in particular, and the ability for everyone in the room to help each other. So, like you said, it's a rare cancer, and it's sometimes I mean, I listened to some of the talks that were delivered on the day. It's so rare that you walk around to think, why me? But the support within the charity is fantastic. And the fact that actually a patient can touch base with yourself or other members of the charity to get ideas in terms of treatment, I think is key and essential. And without that support, I don't think any of these treatments would have developed at all. So it is a support from groups like yourselves and working with clinicians, people like Neil, that pushes these sorts of treatments along.
Yeah, I mean, we all owe a million thank yous to Joe Gums and the team
Mm.
at Ocular Melanoma UK. Anything stayed with you in kind of upon reflection, apart from your lovely lady who's gone on to win the bowls tournament? That's just wonderful. Um, how how has this affected you?
I think it's completely changed my approach to interventional oncology generally. So I suppose as any clinician, surgeon, or whatever you do sometimes get carried away and you sit on the whole rat race and forget why you're actually doing what you're doing. And it can be quite difficult sometimes, uh, particularly working in a cancer hospital. Really appreciating the emotive side of someone's diagnosis. And I think going and talking at the Ocular Melanoma charity in particular really did hit it home. And it was talking to patients during the lunch breaks or during the coffee breaks we had and listening to their experiences and their feeling of being a little bit lost when they've had the diagnosis of a rare cancer, and being told that there are a few options, but if it does spread to the liver, there are a few less options. And to here's a leaflet and walk away. And actually, we could do a bit better than that, can't we? So I think that's where I've really pushed as much as I can to try and drive treatments, because I think that it really has an effect on a patient. And I remember there's another patient I had, relatively a young patient with a young family, who is doing really well, but it's her children, the same age as mine, and it's having that connection with that patient that really affects me. And what it does, it just drives us and myself and a number of my colleagues who perform chemosaturation along to open up more trials, to open up more options, to also go to Parliament to give a talk about how this treatment is effective. So it's affected me in a couple of ways. Number one, I think it's just giving me that extra drive that I need just to really push as much as I can. And number two, it's great to see the community of patients and how they support each other. So yes, it's a very difficult undertaking sometimes, but it's worthwhile. Absolutely, it's something that I actually enjoy doing, and I enjoy really seeing the effect it has on patients as well, particularly when they come back to clinic and they're looking fantastic.
Well, thank you so very much for your expertise, your knowledge, your passion, and your support as well, Pav, through all of this. You're a wonderful advocate for us all, and our working relationship, long may it continue.
Thank you.
If you or someone you know has been affected by the topics discussed in this episode, support and information are available. You can visit Ocular Melanoma UK at www.omuk.org for guidance, resources to connect with our helpline, and others who understand. Remember, no one should face ocular melanoma alone.